Good evening, everyone. I'm presenting case of Mr. Vipin, a 66-year-old male resident of Rajendranagar who presented with complaints of fever on and off for past 1 month, nausea and vomiting for past 15 days, dry cough for past 7 days, and reduced urine output for 1 day. So the patient was apparently well 1 month back when he started having fever. It was low grade, mostly around 99 to 100 Fahrenheit. There was no diurnal variation. It was not associated with chills. He used to have these episodes nearly every day. He also complained of generalized weakness which was associated with it and used to get fatigued very easily. Then he also started having complaints of nausea for past 15 days which was accompanied by vomiting occasionally. The vomitus contained food particles. There is no history of hematemesis. He also complained of reduced appetite. Patient also developed complaints of dry cough around 7 days ago. It was not associated with expectoration. There is no history of any hemopsis. For his complaints, he then referred to a local practitioner where he was detected to have raised blood pressure, which was around 150 by 100 millimeters of mercury, and he was started on some antihypertensive medication and was advised some blood investigations, which revealed a raised serum creatinine. So then he was referred to a nephrologist. He referred to nephrology OPD at Max Hospital, Vaishali, where he was advised further investigations. He then presented to the emergency the very next day with complaints of reduced urine output. He was admitted in ward and on evaluation he was detected to have a further deterioration in renal function. In view of reduced urine output and advanced azotemia, an IGV HD catheter was inserted and he was initiated on hemodialysis. On the very next day, a kidney biopsy was done and the treatment was modified as accordingly. Then he was discharged on some maintenance treatment and was on maintenance hemodialysis. There is no history of shortness of breath, orthopnea, PND. There is no history of swelling over the legs or body. There is no history of any preceding sore throat, skin infection. No history of hematuria. No history of nocturia, polyuria. No history of any loose stools, pain abdomen, dysuria. No history of any rashes over the skin, photosensitivity, or any ulcerations. No history of any joint pain or swelling of joints. Past medical history. Patient had hypothyroidism for past 3 years and was on tablet Thyronorm 75 micrograms once daily. There is no history of hypertension or any other preceding illness. Patient is a non-smoker and used to take alcohol socially. So to summarize, we have Mr. Vipin, a 66-year-old male who presented with complaints of fever on and off for past 1 month, nausea and vomiting for past 15 days along with dry cough for past 7 days and reduced urine output for 1 day. On evaluation, he was detected to have renal dysfunction which continued to worsen. So he was initiated in hemodialysis and a native kidney biopsy was done. And he was treated as per the reports and was discharged on maintenance hemodialysis and medication.
Go on, complete it.
So on examination, the patient had a height of 5 feet 10 inches and a weight of 72 kgs. The blood pressure was 140 by 90 millimeters of mercury, which was taken in right arm in sitting position. He had pallor on examination. There was no icterus, no clubbing, no cyanosis, no lymphadenopathy, no pedal edema, no rash on examination. On systemic examination, there were bilateral basal crepitations, few basal crepitations. The rest of the systemic examination was unremarkable.
Okay, you want to give us some kind of a diagnosis now?
After
You've completed your history and examination, right?
So after the history and examination, this is a case of acute kidney disease, and the causes, my differentials, further differentials would be first would be RPGN, the second would be AIN, third would be MGRS.
How many patients do you think you would see who come in with nausea, vomiting, and uremic symptoms, and they have small shrunken kidneys?
No.
How often do you see this? And they are advanced CKD.
Not much.
Not
Not
much?
much. Not much.
कैसे हो सकता है? सबको दिखता
उल्टा
है.
है वही आते हैं
90% तो हमारे को
वही
जो
आते
14-16 के क्रिएटिनिन होते हैं, नोजिया वॉमिटिंग होता है, फीवर होता है, बट वो फीवर अब टीबी का फीवर होता है क्योंकि वो इतने malnourished हो रखे होते हैं. Yeah, some other infection that is there. So I know they've done a biopsy, which is completely prejudicing your mind. That your team has done a biopsy, so there must be something there, right? But when you're listening to this story, a large fraction of these kind of patients are going to be advanced progressive CKD. So I would not close the chapter on that. It is fine. AKI is high on your list, RPGN is high on your list, they've done a biopsy, so it's likely that the kidney is not so drastically shrunken that they couldn't put a needle in it. So all of that is there, but you can't present something like this to India. If it was US, I would say maybe. People get their BP checks, people get their stuff. Here, CKD has to be, progressive CKD, advanced uremia has to be on your list. So,
You can keep it as a next possibility.
absolutely. So, you have to have that on your
or
differential.
at least maybe an acute on chronic kind
Acute
of
on
a
chronic.
situation.
Yeah.
So whenever you are confused whether it's chronic, acute, and acute on chronic is a safe way out. It's a middle road path. It's a safe way out. Because nobody has. Did this guy ever have a health checkup?
Actually, he
Presumably he's non-diabetic, hypertensive, but a routine health checkup, any BP
Hypertension
checks.
also, you're
also
just
is
saying just 1 week.
150, 100 is
And only
hardly
1 week
anything.
ago.
Only
1 week or 2
1 week
weeks,
ago.
1
Just
week or
1
2
week.
weeks ago.
So
So
no
previously
checkups ever.
he actually denied any such any health issues in the past before all these things.
सबको यही बोलता है.
सबको ये
16
even
साल वाला
diabetics
भी
say the
16
same
साल
thing.
वाला भी ये बोलता है, 40 साल
Even
वाला भी यही
diabetics
बोलता
say
है.
that. हम तो बिल्कुल ठीक थे.
So,
You have to ask them diabetes है नहीं है. That's my usual experience every
and
day.
have they ever had a BP check at all from anyone for any reason? खांसी जुकाम के लिए भी डॉक्टर के पास गए थे तो बीपी चेक हुआ था, तो उस समय क्या था? Many of them, when you start inquiring there,
They are
yes,
detected
4 years ago I had a BP check, they had said 150, 100 and said कुछ खा लेना या तुम अभी बीमार हो तो उसके कारण होगा, and never checked again, never treated again, and lo and behold,
But he denied any such history.
denied means never checked or checked but BP was normal.
Checked but normal before all
Okay.
these things.
Okay.
Yeah, you could specify that.
Yes, because
and lastly,
if you-
at what point in this time course did you take this history, or were you part of the treating unit?
This history when he presented to the emergency
To
on
the
day
ER.
one.
So then how are you saying that
Yeah,
he
then
got
discharged,
then don't put
biopsy.
in that he got dialysis and biopsy? If you saw him in the ER and you're presenting him from the ER, then how do you present him as dialysis and biopsy?
Because he was further treated as that.
So then
No, Richard, there is a difference.
Yes.
On what basis are you giving a certain diagnosis? So it begins with that time frame. So if you took it in ER, all you had, the only data you had was fever, weakness, cough,
nausea, vomiting,
and
decreased urine output, high
decreased
blood
urine
pressure.
output. That's it.
Then don't go into that he's had dialysis and biopsy.
So-
because now if you're saying he's had dialysis and biopsy, you're seeing him at follow-up while he's come for dialysis.
You've
or he's
seen
come
him
for
until discharge.
Yeah.
Or near
Or near
discharge. So as per your presentation, you have seen him near discharge.
Near discharge or after discharge when he's come back for repeat
For
dialysis.
a follow-up
For
or
follow-up
something.
or dialysis.
Something like that. So you have to be, if you are part of treating unit, then you have to be smart enough to kind of time your history at a certain point and process it accordingly. That's being smart.
नहीं, ये तो यहाँ पे तो you are doing it, you have ongoing basis, but in the exam it will be a time point when you get that history. So when we do this for practice also, you have to pick a time point. Even if you know the whole history, pick a time point at which you are saying now I'm taking this history and this is the time point that I will close it at. It can be real time point, which is when you did it, which is fine, but can't be that you do both sides, because then the exam is also a problem. Because what exam are you presenting? Are you presenting the exam that he presented when he in the emergency, or the exam that he presented after he's had 3 dialysis sessions? Because then the exam is also going to be very, very different. If he's had 3 dialysis sessions and you've taken volume off and he came in with edema and that edema is no longer there, then it's very different than when he came in first time. So the blood pressure that you present, those would also be different. So pick a time point. The exam, the history, all of it should be from that same time point.
Yeah. And it should relate to that.
So coming back, so your differential is right now AKI.
First and then acute and CKD.
Okay.
These two are the possibilities.
Okay. And within AKI, you said RPGN, and then you said 2 others, which was also very, very narrow. So you said
Yeah, even
RPGN,
RPGN is narrow for me.
RPGN, AIN, and MGRS from.
Yeah, that's
So
really
yes,
narrow.
we see again whenever you whenever you are now talking and presenting differentials, this is asking for it. You are now asking the examiner
To trouble you.
take you to MGRS and ask you point blank, what is MGRS, where is it, how is it, why do you think this is likely? So now you're opening the Pandora's box on getting grilled on MGRS. So it is good if you're completely covered, then absolutely open the Pandora's box. If you know that when you go in there, you can kind of do 6 hitting on the Yorkers that are coming to you. Because you say MGRS for someone where there is nothing that you have presented so far. There is nothing in the history. There is to suggest, other than he is 66. There is nothing to suggest that this is MGRS. So you open MGRS door, this is going to come back. So be very, very careful. Start broad, especially in this kind of a story. You have nothing. You have fever, cough, nausea, vomiting, urine output, BP, and a kidney biopsy and dialysis.
Though the other problem is MGRS is a very, very difficult diagnosis to be clinically guessed.
Yes, but it could
No,
present
how
as
do you guess? How do you
rapid
guess for
screening.
MGRS? I really
present
don't
as
know.
anything. So, which is why are you saying MGRS? Why not just myeloma? Why not polyclonal
Yeah,
disease?
MGRS is a specific entity. Should have
So-
no systemic things.
So you can even say this could be one component or some part of myeloma, MGRS, and that spectrum of disease. So that can be a possibility. Why not? Because now you're opening my MGRS. They will ask, why can't it be light chain nephropathy? Right? That will be my next question. Why is not light chain nephropathy on your differential?
But okay. But it could be a part of spectrum of myeloma and MGRS
No,
spectrum.
so
we can say.
myeloma related, let's say AKD.
AKI.
It's still understood. Myeloma related AKD, whether it's light chain cast nephropathy, whether it's proximal tubulopathy or amyloid or whatever it may be. 3-4 things that exist. But to clinically guess that somebody has MGRS, okay, let's take it the other way. How does commonly MGRS present? Is it AKD?
No.
Then why bring it here? You've answered yourself, right?
Right.
So what does it present as usually?
Usually the patient has complaints of backache or bone.
Give
bone
us a syndromic thing.
नहीं
वो भी नहीं होगा.
वो नहीं होगा.
वो तो बिल्कुल नहीं
वो
होगा.
फिर माइलोमा हो गया. अगर उसको बोन पेन हो रहा है एंड उसको बोन डिजीज दिख रही है तो फिर आप माइलोमा बना दोगे. So MGR is, see again, that's what I'm saying. So now,
So what he's saying is correct. You got trapped into it.
So that's what I'm saying. So the problem is you didn't need to. This discussion didn't need to happen here at all. We didn't need to go into MGRS at all. We were talking AKI, CKD, RPGN. हम MGRS और myeloma और light chain में कहाँ पहुँच गए? है ना? The reason we got there is because you put MGRS as a differential, which absolutely didn't need to be there. So be very, very careful when you have your case. After you finish, take 5 minutes. Write a big, broad differential. Don't get narrowed into, and especially not if you know the diagnosis of the patient. start broad, keep everything on the table. Don't lock yourself in. Yes, make a priority. Once you've written your broad differential, say which one do I think is 1, which one do I think is 2, which one is 3, 4, 5, 6, 7, 8, 9, 10. But keep everything on the table. And this will help you not just in the exam, but also in real life. Because the more you lock yourself in, the less likely you will actually be even able to think that this is something outside. And the more likely that you will get surprised in more number of cases in life. इन दी एग्जाम तो एग्जामिनर आपको उल्टे डायरेक्शन में पकड़ लेगा. जो सीधा सीधा केस था उसमें भी लेफ्ट में घुस जाओगे और वो लेफ्ट फील्ड से फिर वापस पटरी पे आओगे ही नहीं, क्योंकि अब तो एग्जामिनर पूरा लेफ्ट फील्ड चला गया. AKI RPGN का डिस्कशन होना था, मैं खाली CKD ऐड करना चाह रहा था, CKD AKI on CKD on board, but as soon as you start पटरी उतर गई.
So अब इस पटरी उतरने से वापस आने से पहले let's figure out why this can't be MGRS. And उसमें यही है पहले कि कैसे present करता है MGRS. Somebody else can pitch in here. I mean, it need not be richer necessarily. Why is this not MGRS? Let's very simple question.
मैम बहुत हाई चांस है MGRS निकलेगा. वो डिफरेंशियल नहीं इसीलिए क्योंकि बायोप्सी से देखते हैं. वो हमारी प्रॉब्लम है. Yes. वो हमारी प्रॉब्लम है. We are going by not have it or may even have it, but they are going to mark you on the approach.
Exactly. Approach is important. जो हमें डेटा दिया उसमें ये MGRS नहीं है. ठीक है. अब MGRS क्यों नहीं है? So first thing we need to know how does MGRS present. So somebody
What are the different
usual presentation commonest बता दो बस बहुत है. Okay. Usually
so one option
they
is
would present as nephrotic.
What else? Biopsy पे क्या क्या दिखेगा? What are the different glomerular lesions or other things that you will see with MGRS?
बायोप्सी से पहले सिस्टमिक साइंस क्या होंगे? कुछ होंगे? नहीं होंगे. इसको तो बहुत सिस्टमिक प्रॉब्लम्स हैं, वीकनेस, नौसिया, खांसी, बुखार, ये सब होगा MGRS में. So clearly MGRS इसीलिए तो रीनल लिमिटेड है वो बीमारी. Right?
MPGN type pattern, PGN MID, those are kind of, you may have some, but the MGRS will not be your light chain cast nephropathy, because that will be, by the time you get that, you will be close to myeloma or actually myeloma. They will very rarely be, the MGRS ones will be those clone दिख ही नहीं रहा है, मिल ही नहीं रहा है.
उसमें मिलता ही नहीं है.
मिलता ही नहीं,
ढूंढने से भी नहीं मिलता.
या बहुत low level clone है. So those are the ones which will become MGRS. The ones that are full blown, that get fever, that will get infections, that will have severe anemia, those have bone pains. They will have their systemic myeloma. So they will be full blown myeloma, not MGRS, because the disease and the spectrum of disease, the presentation will be very different. So light chain deposition disease, amyloidosis will present as nephrotic. The others will present more nephritic MPGN type pattern with nephritic kind of presentations. And by the time they get to dialysis, in MGRS, who gets to dialysis? MGRS that gets to dialysis. Predominantly light chain cast nephropathy. Means you block it up, you ramp up, and you knock the kidney off very, very quickly. Your other ones will be slow progressive disease. They will not rocket up. So again, if you were to make this into a monoclonal related disease, I would say light chain cast nephropathy
would be the
one that you would say would be this. Not something where you are looking at PGN MID and MPGN, वो धीरे-धीरे खिसकता जाएगा, but सीधा.
So for that, the best broad term would be paraproteinemia related acute kidney disease. Yeah. So which will cover everything. It doesn't define myeloma, but it kind of gives you a broad category.
And whenever you put that on your differential, be prepared to then get asked about it. So whatever you put on your differential, you have to be ready to then cover your base on it, right? Can't be that you open up a flank and you have no defense around it. So open up flanks only when you have defensive shield to protect you, है ना? नहीं तो वो खोलो ही नहीं. कोई खुलवाए दरवाजा तब तो खोलो. पहले से खोल दोगे तो फिर तो आर्मी अंदर घुसेगी, है ना? ठीक है. Okay.
चलो अब कुछ acute kidney disease पे वापस आ जाते हैं. So RPGN is a clinical term, pathological term, what?
RPGN is rapidly progressive glomerular nephritis, so it is defined clinically as the progression of the disease is very rapid. It takes few days to weeks.
Okay, we'll buy that.
And on pathology?
On pathology, there are crescents in the biopsy, so it is also known as crescentric GN.
Okay. So usual when we label something as RPGN, many times we synonymously consider it with crescents. But RPGN is clinical, crescentic is pathological, and many times they may be discordant and there may be other things that can happen there too. You get an RPGN with ATN also. You think it is RPGN and then it turns out to be, which is not on your list. You have AKI, you have AIN, you have RPGN, but why is ATN not on your list? No. So
Can be there. 18 can be there.
18 can be there. So AKI बना रहे हो तो ATN
So was
तो
there in all this, except the treatment part, especially in the ER, was there any reason to call it a glomerular disease? So fever, weakness, nausea, cough, it doesn't tell you there is a glomerular disease. It could be, as he said, it could be ATN, बुखार है, dehydrate हो गए, इधर उधर.
The history is actually, the history spans over 1 month. So the patient was having these symptoms for past 1 month. He was having almost daily episodes of fever and nausea and vomiting. And he then developed cough for past 1 week. So the symptoms were progressing in a way. And the age is also more than 60 years. And he does not have any previous history of diabetes, hypertension. He was recently detected to have raised blood pressure when he went to check up.
So for the 1 month, what was he doing?
He was just taking symptomatic treatment. He was just taking paracetamol for the fever.
For
Some
1 month, he
PPA.
didn't show to anyone.
No, he only when he started having cough, he then showed to the local practitioner.
Okay. And no injections given,
No.
alternative medicines taken.
No history of alternative medication. He used to take paracetamol for the fever. That's what he told.
बहुत ही सीधा साधा इंसान है.
Yeah,
महीने भर हाँ
या
महीने
बुद्धू
भर
है.
से बुखार चल रहा है कुछ नहीं
No,
मिला
even
कुछ
for
नहीं खिला.
AIN, you need some medication
Some
history.
medication. Yeah, but he does not have any history.
No antibiotics, no nothing. खांसी के लिए भी एंटीबायोटिक नहीं मिला, खाली पैरासिटामोल खा रहा था.
When he started having that dry cough, then he referred to the practitioner, local practitioner.
So got some antibiotics, got only paracetamol.
He actually denied taking any antibiotics. He just said that he was detected to have raised blood pressure, so he started on medicines for that, and then the blood test showed raised creatinine. So then he was referred.
A little hypothetical now. So you said you took the history in ER. Let's say with this, what was your first guess? ER level. You didn't have a urine examination then. तो RPGN भी कहना बहुत मुश्किल है. So what was your first guess?
My first guess was that he is having some sort of infection, and then it has worsened, and he is having AKI because of that.
That makes more sense to me anyway, at ER level. Okay, if you, let's say this guy was investigated and no cause for fever found, he doesn't, or in other words, 1 month history, non-infective reasons for a similar sickness. What would that be? First on your line, 66-year-old male.
First would be malignancy in this age group. He
I
can
didn't
have
think
that.
of malignancy though. I was thinking in terms of nephrology.
Oh,
Okay, let's think in terms of
terms
nephrology
of
since this is a nephrology domain.
With this kind of history, when he's having those symptoms for past 1 month, so he can have vasculitis
Yeah, that I think is the best guess that you can make apart from tuberculosis. You get this history in ER for 1 month. My first guess would be TB or vasculitis in this country. If this was
Yeah, and
a non-TB country, I would say vasculitis. If it's a TB country, I would say TB.
you started off fever 1 month, cough, nausea, vomiting, low
sounds
urine
like-
output. You have RPGN on your list. Vasculitis is going to be high up there. So there is absolutely no doubt. ANCA vasculitis, anti-GBM would be high on the list for someone with that kind of a story,
Right.
with that age group. So that's definitely on there. In terms of your exam, which side or where does it kind of point you towards? Because your exam,
On clinical examination, the blood pressure was little on the higher side, and he had pallor, and there were some basal crepitations on auscultation.
so what does that, with
So-
no edema?
There's no pedal edema.
No pedal edema but basal crepes. So what does that mean?
So maybe he's having this chronic inflammatory process, because of which he's having this maybe he's having any pulmonary any alveolar hemorrhage, because of which he has been having this anemia, and there is
Alveolar hemorrhage से anemia होता है?
if there is
Hemorrhage तो पहले दिख जाएगी.
if there is renal if
There's
there
no
is,
hemoptysis history here.
but it may not be there.
So all of that is fine. How much alveolar hemorrhage will it need for someone to drop their hemoglobin from 12 to 5 or 6 or 7 for you to be able to see pallor? Right? So again, the pallor and the anemia is not due to alveolar hemorrhage.
It-
How much so
It's like a cerebral bleed. So you never get anemic because of a cerebral bleed. The neurological symptoms come first. So for alveolar hemorrhage, somebody would get breathless, get hemoptysis, and get hypoxic. Hypoxic. Those three things
If there
any
is a
day would.
massive alveolar hemorrhage, then we can get those symptoms. But if the minor things are happening, then the patient may not be that symptomatic.
So, what our
Common
issue-
things first.
Yes, our issue is the anemia that is going to happen in an ANCA vasculitis is not due to alveolar hemorrhage. It is due to
Renal failure.
Due to what?
renal failure with EPO deficiency and
Or
inflammatory disease.
inflammation.
Inflammatory disease which has
disease.
been going on for some period of time. It is not, the amount of alveolar hemorrhage is not going to be. If the amount of alveolar hemorrhage is that much that the hemoglobin actually drops, they're going to be dead. Right? Because their lungs are going to get flooded. So that is not the mechanism for the anemia. So if you have pallor, you have basal crepes without edema, right? So what would be the differentials that you would come up with? Sure. Pulmonary disease with vasculitis with the kidney involvement, sure. What other things would you think about?
He started to have fluid overload.
So in our patients, when they get fluid overload, where do you see your patients getting fluid overload? What symptoms and signs do you see?
In case of fluid overload, they can have peripheral edema, and then they can have fluid when there is pulmonary edema, they will have crepitations, they will be breathless.
So you see this every day. When do you see a dialysis patient with pulmonary edema with no pedal edema? When do you see that? Acute LVF. So what kind of, so they would have to have some cardiac or valvular issue for them
Cardiac
to have
disease.
for them to have no pedal edema but to have crepes, or they need to have lung disease where you're getting lung disease related crepes, interstitial lung disease, ANCA related lung disease. So if you're saying that there are crepes with no edema, then your mechanism of those crepes can't be volume overload. बिकॉज पल्मोनरी एडीमा तो से पहले तो बहुत पहले पीडल एडीमा आएगा. आपके पीडल एडीमा वाले 8, 10 सेक्रल एडीमा भी होते हैं, उनको क्रेप्स नहीं होते है ना. दे हैव लेग एडीमा, थाई एडीमा एंड दे डोंट गेट क्रेप्स. बाय द टाइम दे गेट क्रेप्स दे आर थ्रू द रूफ. So when you're now describing someone with crepes with no edema, you have to have a differential for it, and that differential will include vasculitis, which is definitely on board, and which is what I was thinking you would say, that this is pointing me to vasculitis, I have an RPGN, I have fever, cough, nausea, vomiting, urine output that is decreasing. This is AKI, RPGN, and because there are Krebs with pallor and no pedal edema, vasculitis is my top differential with lung renal syndrome, not any kind of random kidney disease with volume overload because there is no pedal edema. So that would put in my mind, that would put me on vasculitis very high with this, or some kind of interstitial lung disease. So now you're talking autoimmune diseases that have lung involvement with kidney involvement. So that would be another component, especially if this was, let's say, a 50-year-old female, then that would go high up on my list. Okay. So coming back to differentials, and what do you want to kind of do for this patient?
Urine examination.
Urine examination.
Big thing missing.
Yes.
For a urine examination, there was 2 plus protein in the urine. RBCs were 15 per high power field and WBCs were 2 per high power field. No casts were there.
आपने देखा था, किसी और ने देखा था?
देखा
thought I
देखा।
last
मतलब लैब से भी था, हमने भी देखा था।
आपने देखा था? ओके, ठीक है। RBCs कैसे थे?
RBCs fuzzy margin.
Fuzzy margin. Okay.
Small.
So how many here have looked at spun urine for their GN cases or AKI cases and looked at it themselves under the microscope with a lab tech?
Once,
Twice. See, again, I would say it's
दो चार बार
this
देख
is-
लो at least.
See, this is something that is so useful if you start learning it. Doesn't require a lot of stuff. सबके फोली डली पड़ी होती है, फोली से निकाल लो. Keep a specimen container. सबके पास वहाँ पे specimen bag होता है. लो, अपने पास रख लो. Go to the lab, spin it with the technician and look at it. Do it at the end of the day, before going home. So you're not under pressure or stress or anything. You can collect it in the day and take it and look at it in the evening. Doesn't matter, कुछ major खराब नहीं होता उसमें. But start doing it because you will start noticing and seeing. ATN में तो muddy browns आप भर भर के देख लोगे. You start doing it, you will see. मतलब so much so that वो urine देख के आप बता सकते हैं मेरे को muddy brown दिख रहा है इसमें तो. मतलब visual दूर से ही. Not कि spin करना है, but again that will take some habit to look at it. And RBCs में cleanated RBCs हैं कि actual schistose हो रहे हैं, which are due to glomerular disease. You will start noticing the Mickey Mouse ears and the snowman. Even without polarizing light. Polarizing light है तो फिर तो बल्ले बल्ले. But you don't have a polarizer also. You will start noticing those only if you have seen at least 15-20 of those GN slides where you expect to see them. So then you'll start noticing them. You'll be able to see. नहीं तो फिर वो fuzzy नहीं होता. So they can be crenated. There can be that. But
I think we've reached a point when they've never seen it. I think that's a bigger problem. At least कुछ तो देख लो. I mean, I'm sure you guys will never reach what Ajay is saying. But somewhere at least see them. 4-5 बार देखोगे, at least you will learn to differentiate RBC from WBC maybe. इतना तो कर लो.
And जो हैं जिनके आप बायोप्सी कर रहे हो, बायोप्सी से पहले एक यूरिन तो देख लो. यूरिन एक रख लो अपने पास. जिसकी भी बायोप्सी कर रहे हो
देख लो, कुछ तो देख लो.
Again, the point is not just about learning to see the urine. You will then also for the exam be able to appreciate, okay, I looked at the urine, I've done the biopsy. The biopsy is going to come in 2 days with the report. This was what I saw in the urine. Based on the urine, make in your mental mind, this is what I think is going to come out in the biopsy. Right? So again, whenever we do a biopsy, everyone asks, what is your top 1, 2, 3? The purpose of that is not to try and grill you. It is to increase thought process of, okay, I put my money down, this is one. And then when the report comes and it's number 4 on your list, or it was not on your list, then it reminds you your list is too narrow. Make broader lists so that you understand that this kind of presentation can also come from this disease. If you don't put it out there, you don't write it down, when that report comes, it's there. It won't make you think about, okay, what is your differential and why do you want to make a broader list? So just write that down. And whenever you do a biopsy, if you even do that, whenever your patient is getting a biopsy, you look at the urine, you will be golden by the time actual exam comes.
Then you've covered a lot of glomerular diseases. Then obviously the wide spectrum, you've covered all that.
Yeah. And 2 ATN के यूरिन स्पिन कर लोगे, वो एक हार्ट फेलियर वाला का ले लेना, भर भर के हाइलिन कास्ट दिखेंगे. सो एनी हार्ट फेलियर पेशेंट विद इन किसी भी सीसीयू में जाके जिसके लिए आपको कंसल्ट आया उसका यूरिन निकालो, यू विल सी टन्स एंड टन्स ऑफ हाइलिन कास्ट. Some of them may have gotten to muddy browns if there is now ATN, but you'll see tons of hyaline cast. So those are things that once you've seen, you're done. एक nephrotic का lipid polarizer लगा के cross, Maltese cross. Those are things once you've seen, they're imprinted on your mind. They're imprinted on your mind. You'll see those and you're done. ठीक है, okay. So 2+ protein, 15 RBCs.
So here is your answer to the glomerular disease, the urine routine. Right? So that's the value of urine routine here. You can at least, there is a pointer towards glomerular disease, right?
So from a workup standpoint, we'll start from the ER rather than from here. So what would you want to do in terms of workup for the patient when the patient's in the ER?
So first of all, we'll go for the blood test CBC, KFT, LFT and the urine examination and ultrasound of the kidney. We'll also quantify, we'll do a spot urine PC ratio for this patient.
Or?
And
something else, this guy has a lot of symptoms. A chest x-ray at least.
Yeah.
Chest x-ray and a blood gas.
And a blood gas.
Yes. So ER में तो सबसे पहले ब्लड गैस करके देख लो कितने पानी में हो. ठीक है. So do you have those as well with you?
I have the blood reports and the findings of the X-ray.
ठीक है.
Go ahead.
So the CBC in the CBC hemoglobin was 8.9, TLC 12.3, the platelet count was 3,37,000, and the MCV was 85.1, MCH 27.1, MCSC 31.9. Then 75.2% were neutrophils, lymphocytes were 7.7%. Then for the kidney function test, the creatinine was 9.6, the sodium was 126.4, then potassium was 4.8, calcium was 8.4.
So whenever I hear this, वो मेरे ना कान अटक जाते हैं. So sodium was 126.4. Do you think the lab is that accurate? Again,
I would never look at a decimal point for sodium.
So again, that's what I'm saying.
I don't think I have ever done it. 129, ठीक है. I don't think I look beyond that decimal.
So again, the
for
reason
sodium.
So the reason I bring it
130
up
में
is
point बेकार है.
because you said it, तो अब वो कान में
I didn't even hear it.
So वो कान में अटकता है तो फिर वो दरवाजा खुल जाता है. So अब 126.4. Do you think the lab has accuracy level? So it's similarly when you say a creatinine of 1.95, right? What's the coefficient of variation on creatinine or on sodium, right? So the lab doesn't have accuracy at that level. So don't present it like that. If a lab person does it and they don't know about it, उसने report कर दिया. But as a clinician, we have to know 1.96 का कोई मतलब नहीं है, right? The lab coefficient of variation on creatinine is 15%. Same lab, same time, 10 times, you have 15% variability. So 9.6 का तो कोई मतलब ही नहीं है. So similarly on sodium also, there is a significant they will themselves, the lab will say, they will give you a report with plus minus 3-4%, which on 126 is there. So 0.4, 0.5, तो third
I
decimal के
think
बाद
your
तो
mind
बताओ ही
should be
नहीं.
trained not to look at it. At least,
And
I mean,
so-
while you brought it out, I never look at it.
वो सुनते ही अटकता है.
अटक
तो
गया.
अटक गया.
So
sorry.
I think
We
gradually
can
one
go
has
there.
to learn not to kind of.
Yes, so because the more you say
makes
these
no
kind of
sense.
things, the more likely that the consultant is now asking you on things which otherwise wouldn't. 0.4 हो गया, अब बताओ मेरे को सोडियम की वेरिएबिलिटी है, सोडियम नापते कैसे हैं, है ना? Where are the issues? Why do you have pseudo hyponatremia? So now you've opened another box. So stick to straight things, straight सवाल. चल 126. ठीक है. Next और क्या था? So sodium is 126, creatinine is 9.6.
Potassium normal था कुछ.
Potassium 4.8, urea was 136. Then in the liver function test, the total bilirubin was 0.5, direct 0.2, indirect bilirubin 0.3, AST 34.4, ALT 19, total protein 7.8, albumin was 3.5, the Ag ratio was 0.81, the globulins were 4.3. Then urine PC ratio for this patient was 1.32.
अरे आपने अपना डिफरेंशियल का सबसे बड़ा वाला तो बताया ही नहीं. कैल्शियम फास्फोरस तो बता दो.
हाँ,
बताया था normal.
8.4
अच्छा,
and
बताया,
phosphorus was 5.2.
बताया था कुछ normal
ठीक
types.
है. Okay, ठीक. मेरा
Chest
miss हो गया.
X-ray,
Chest X-ray had prominent bronchovascular markings.
which means nothing usually. Okay.
The ultrasound right kidney was 9.7
Oh,
centimeters.
that's all the X-ray had. Nothing else.
Nothing else.
Okay.
Left kidney 10.3 centimeters, and it was reported as bilateral increased cortical echogenicity with maintained CM differentiation.
And blood gas.
The blood gas analysis, I don't have that report.
Okay. And UPCR.
1.32.
Okay. So now with all of this information, what's on your list and what's off your list?
RPGN is still a possibility in this case because
Do
we
you
are
want
getting.
to change these places, RPGN and AIN?
RPGN is most likely possibility because we have an active urinary sediment and there is renal dysfunction. The kidneys on the ultrasound are of normal size and there are no chronic changes in the kidneys.
No chronic changes.
The size is okay and the corticomedullary differentiation is okay, but yeah, they appear echogenic.
फिर
Echogenicity is chronicity.
it is chronicity. So ये तो ऐसा वाला हो गया. ब्रेन में मल्टीपल पुराने इन्फार्क्ट्स हैं, एट्रोफी दिख रही है, पर ब्रेन तो ठीक है.
वो तो न्यूरोलॉजी वाले कहते हैं.
डिमेंशिया हो रखा है बंदे को, पर ब्रेन तो ठीक है, ब्रेन का तो कोई प्रॉब्लम नहीं है. तो डिमेंशिया का कारण क्या है? यूरीमिया है ना, क्योंकि यूरिया उसका 100 है. भाई जो ब्रेन आधा उड़ा हुआ है. So again, when you have echogenicity that is increased,
That's chronicity.
there is some chronicity. Yes, it is not bad enough to say that we don't want to biopsy the patient. So that's a different discussion, but we can't say that it is normal. There is echogenicity there. So that's okay. Okay. So RPGN is on your list. Again, still too narrow. Open up the differential. खाली एक पे लॉक हो गए. RPGN. इधर से वो तो उसको तो बायोप्सी पता है, आप लोगों को तो बायोप्सी नहीं पता है, हमको भी नहीं पता है. Okay, post infectious.
So so that's in a way infection related, post infectious is that.
मिस हो गया.
So it's still RPGN in a way,
RPGN,
but
ठीक है.
post
Post-infectious.
infectious. But the infection related.
Okay, so PTH and vitamin D, ठीक है.
What will you do with those?
Okay, AKI on CKD or CKD by itself.
Okay.
ठीक है. PTH
So PTH,
PTH
vitamin
and
D has
vitamin
nothing
D
to do
was
with
not
it
done
even
in
then.
this
not done. RPGN, PTH भेजा ही नहीं. ठीक है.
So again,
ठीक है.
vitamin D is not related there.
हाँ, ठीक है.
So check that
और
out.
कोई? और डिफरेंशियल तो बनाओ यार. वो तो यार आरपीजीएन में अभी सब पकड़ लिया. मैं वही कह रहा हूँ, आरपीजीएन को छोड़ो, है ना. ग्लोमेरुलस के अलावा भी चीजें हैं. अभी एटीएन हो सकता है, एआईएन हो सकता है, एकेआई को छोड़ के
So the
सीकेडी बना सकते हैं,
proteinuria is
सीजीएन
very
बना
little.
सकते हैं. एआईएन कैन बी देयर. चलो अभी अभी हम
maybe
अभी हम
he took
वो
other
कर ही
things
नहीं रहे.
also.
अभी मैं वैसे ही
अरे वाह.
डॉपलर तो बताया नहीं, पूछो, है ना. सो अगेन आर्टरी, वेन, ग्लोमेरुलस, इंटरस्टिशियम, ट्यूब्यूल, सब कुछ खोलो. So again, when you do your differentials, start from all the areas, then start all the other infections, autoimmune, other drugs, है ना. Hemolysis.
Viral markers were negative.
Okay. So अब चीजें खुल रही हैं, है ना. So other GNs, खाली RPGN. Other GNs are also. So viral markers मांग रहे हो, good. और
peripheral blood smear for
yes, anemia could be anemia related. क्या हो सकते हैं? Okay, so India में bad malaria that is leading to, yes, you would have expected some amount of urine history in terms of hematuria. What else? AKI with hematuria, with anemia, TMA, फिर और एक IgA. Okay, so crescentic IgA by itself, PNH with AKI, right? Again, history is different, but what I'm saying is, if you start going through all the possibilities and opening up, then your differentials will be broader and wider. So, खोलो, बंद करोगे तो फंसोगे.
So somebody said renal artery stenosis. I mean, it's a good point that you think about vascular.
Think about it. Yes.
Think about artery, glom, tubules, interstitium, and the vein. And the ureter.
Yes.
Not
And
to
the
forget.
ureter, yes.
Not to
Obstructed.
forget. Not to forget.
yes.
So that's what was the classic old-time
Yeah.
thought, that we all thought that way: pre-renal, renal, and post-renal. Okay, but somebody said renal artery stenosis. So why renal artery stenosis? But his sickness is a month old.
ठीक है.
Okay, चलो मान लिया. So उससे क्या होगा?
ठीक है. ओके. अब साथ में और क्या बनाना पड़ेगा? पल्मोनरी एडीमा भी हो रहा है. सो अब तुम बना रहे हो तो फिर पूरा बना लो ना, पल्मोनरी एडीमा भी ले लो, है ना, कि पल्मोनरी एडीमा हो रहा है उसको. सो बना
चलो
लो.
अच्छा, let's put it the other way. What's against renal artery stenosis
yes.
here? Let's make
things that this
things
is
that
unlikely.
tell you this is
It's
unlikely.
Yeah.
देखो
This is
वो
unlikely.
जानना भी जरूरी है.
Yes. So कहानी
So,
बना रहे हो तो बना लो, but
हाँ,
it's unlikely.
खींच
This is
के बना
unlikely
लो,
to be. हाँ.
but it's the least likely,
This
I
is
would
least
say.
likely. Yeah.
But why is it not renal artery stenosis? And renal artery stenosis के बाद मान लिया तुम्हारा ये साहब, मैं भी सबको खिलाती हूँ, खुद भी खाती हूँ, वो भी खिला दिया और उसको AKD हो गया, so called. But why, even then, why is it not renal artery stenosis?
First of all, history is not suggestive of any atherosclerotic disease, risk factors.
You don't get history of atherosclerotic disease. You basically see it. Okay, what are the risk factors? Age तो है 66.
Other than age,
और क्या मिलेगा बताओ? Age, डायबिटीज नहीं है, चलो. और तीसरा हिस्ट्री उसने बताई नहीं.
पीछे से हाँ क्या malignant hypertension. Yeah, you would expect
Hypertension
140,
ही नहीं है.
140, 150 वाला नहीं है.
हाइपरटेंशन नहीं है, सबसे बड़ी बात. हाइपरटेंशन नहीं है. और तीसरी रिस्क फैक्टर क्या? स्मोकर, वो बताया नहीं उसने.
नहीं बताया था, ही इज नॉन स्मोकर.
Non-smoker, alcoholic.
हाँ,
मतलब
चलो,
alcohol, occasional alcohol,
alcohol
not
intake.
alcoholic, but
Right,
yeah,
I always
occasional
find
alcohol.
that.
Yes, occasional alcohol intake.
So
but yeah.
स्मोकिंग नहीं है, ठीक है. सो रिस्क फैक्टर्स भी तुम्हारे कवर हो गए. हाइपरटेंशन ही नहीं है ना. सो फॉर for a renal disease to be renal artery stenosis, you have to have hypertension, primary need. और बताओ, उसके बाद ER में उसके 2-3 examinations हो गए. Let's say urine कर लिया आपने. So now I've given you a strong hint. What is against renal artery stenosis as being the primary sickness here? Hematuria. More than that, more important than that. Proteinuria. Proteinuria is always a reflector of glomerular or tubular, let's say, but let's assume urine routine on a dipstick is definitely albumin, right? So it's a pointer towards glomerular disease. So there are major pointers where you would say this is not renal artery stenosis, right? No, it's a diagnosis, I feel, which fantasizes us. And if you see 100 hypertensions, even if you see, let's say, 100 secondary hypertensions, how many of them would be, can you give me a breakup? Rough breakup, no precise percentages. Rough breakup. क्योंकि रोज हम देखते हैं hypertension. Every day we see a hypertensive who's, let's say, 65-year-old. More than that, I think majority
Especially हमारे पास जो आते हैं,
जो हमारे
हमारे पास आते हैं उनमें और भी ज़्यादा है. अगर unless you have a general medicine clinic, then yes, 20-30% with renal parenchymal. For us, it's going to be higher.
It's like very high, right? And a young hypertensive, the percentage would even get higher. Here there would be a lot of idiopathic hypertension, essential hypertension, idiopathic, whatever we call it. But when we see a young guy with hypertension, even in him, parenchymal disease is much more common than renal artery stenosis. Ikka dukka mil jayega kabhi renal artery stenosis. So it's a diagnosis which I feel we are just fantasized about, but we don't see it in real terms, or see it extremely rarely.
Okay. So what do you want to do for this patient now that you have all of this information with you? You have the 9.6, you have the kidney size, you have the protein. So what do you want to do for him?
So I would like to do further investigations to evaluate for the cause of this.
Okay. So what do you want to send?
So we'll send C3, C4 in this case.
Okay.
So in this patient, the C3 was 170.
नहीं, पहले टेस्ट बता दो, फिर रिपोर्ट बताओ.
Okay.
क्योंकि जब आप भेजोगे तब तो एक साथ भेजोगे, फिर रिपोर्ट तो 2 दिन के बाद आएगी. So आप भेज क्या रहे हो पहले वो बता दो.
C3, C4, C-ANCA, P-ANCA, anti-GBM antibody titers.
Okay.
And then I would like to send kappa lambda, serum-free electrolyte, serum kappa lambda chains and electrophoresis, serum protein electrophoresis.
Okay.
And also the blood and urine cultures.
Okay.
So for all these, except C3, C4, where the turnaround is short, everything else takes 3 days.
2 to 3 days. So अब आप बता दो reports क्या.
चलो हमने भेज दिया, अब क्या किया आपने?
So in this
और
patient,
करोगे rather.
the C3 was 170, C4 was 25, both were normal, and then C-ANCA was negative and P-ANCA was positive. Anti-GBM antibody titers were 451 units per ml. And
How soon do you get this in your hospital?
ma'am, 3 days. C3,
days.
C4 the very next day, and the rest.
So I was right on that, 2-3 days. Okay. Meanwhile, you have done a biopsy.
Yes.
Okay. What did you find on biopsy?
And SFLC and SPEP were negative. And cultures were negative.
Cultures were negative. Serum protein electrophoresis was negative.
And kappa lambda
Kappa
ratio?
lambda ratio was 1.84.
Okay.
So in the biopsy, in light microscopy, there were 3 linear cores which had 22 glomeruli, and all glomeruli show crescents. 19 were cellular, 3 were fibrocellular crescents, and in addition, 8 glomeruli had segmental necrotizing lesions. There was no evidence of thickening of glomerular capillary wall, no mesangial matrix expansion or mesangial hypercellularity, no endocapillary proliferation. Then tubular interstitial compartment showed diffuse acute tubular injury, which was of mild degree, and there was moderate interstitial inflammation in 26 to 30% of the sampled cortex. And interstitial infiltrate was composed of lymphocytes and few eosinophils.
So whenever you hear that you have RPGN with crescentic lesions, when you talk to the pathologist, what's your next question?
Age of
No.
Before that,
No.
percentage.
ना क्या पूछोगे नेक्स्ट सवाल क्या है हैज टू बी IF
IF is the
IF
next
is the
सवाल.
main जैसे ही
Because-
आपने क्रिसेंट सुने भाई अब मेरे को अपने चार्ट में डालना है IF में क्या था
So how does IF will
what-
figure out your diagnosis?
exactly so as soon
So
as
you
you
have 2, 3,
crescent
4 diagnoses.
ask for
Where
IF
do you go?
and then you say okay we'll come back to how many crescents are fibrous how many are cellular what is the IFTA what is the other stuff but first has to be IF क्या था भाई IF बताओ so IF में क्या था
So in this patient, IgG was 3 plus linear along the capillary loops, and IgA, IgM was negative, C3, C1q negative. There were no kappa lambda restriction.
so what does that mean IgG was linear IgG okay so now what do you want to do
Come back to those crescents. 100% you said 90% crescents. How
out
many
of-
cellular?
19 were cellular, 3 were fibrocellular crescents,
Okay, so mostly cellular.
mostly cellular.
Circumferential, chote wala. Now somebody can ask the age.
It is not
what's
described.
what's the usual difference when you look at crescentic GN in anti-GPM
And
versus ANCA?
vasculitis.
Same age.
Same age crescents are there in anti-GBM. In
in
ANCA vasculitis, they can be of different age.
Why?
Because the disease has a relapsing remitting course, so there can be different age groups for the crescents.
Okay. So now with what you have, and you have a P-ANCA which is positive also. So what do you want to label this patient as?
Double positive.
Okay.
Oh.
Do you think the ANCA is actual positive or fuzzy positive?
That can be falsely positive because because of inflammation there is
So first is
It
what was
can
the
be.
titer, and
The-
was this actual? Did they do the MPO and PR3, or did they just do?
actually the MPO was 2 plus
Okay.
in this case.
So this is IFA.
Okay. Okay. So what's the label, and how do you want to treat him now? What do you want to label him as?
Anti-GBM, double positive anti-GBM disease.
Double positive ANCA with anti-GBM.
ANCA with
ठीक है.
anti-GBM.
Okay. And what do you want to do for him?
So in this patient, we'll start with immunosuppression. We'll give him steroids. First, we'll give methylprednisolone pulse therapy, followed by oral steroids in the dose of 1 mg per kg per day, and it can go up to maximum of 80 milligrams per day. And we'll give immunosuppression in the form of cyclophosphamide for this patient. It can be given in oral or IV form, and we'll also start plasma exchanges for this patient. So, all of these things.
So आपने क्या क्या दिया?
In this case, he was given IV methylprednisolone 500 milligrams pulse for 3 doses, followed by steroids, oral steroids at the dose of 1 milligrams per kg body weight per kg per day, and he was also started on plasma exchanges. So a total of 7 sessions of plasma exchanges were done for this patient, and he was also given a single dose of IV cyclophosphamide.
How did you dose this IV cyclophosphamide?
So the cyclophosphamide dose is it's 15 milligrams per kg body weight. So IV dose, and first.
So how much did you give him? What was, you told us his weight was
So how much?
72. So how much did you give him?
He was given
That becomes a gram. 1050.
70.
He was given 750 milligrams.
So वो तो 10 है. वो तो 15 नहीं है.
Actually, the dose of cyclophosphamide is to be reduced for age and renal function.
Okay. So how did you lower it? Means how do you decide which age, where, and when to lower it?
If the patient has advanced renal failure and age is more than 60 years, then we have to reduce it. Ideally, we should reduce it by 50%.
50%.
So,
तो कोई है किसी ने कुछ numbers डाल रखे हैं, कहीं कुछ बना रखा है?
क्लियरेंस के हिसाब से डाल रखे हैं कहीं तो, नॉट दैट आई रिमेम्बर.
Okay. Yeah. So again, so these are some from the UK guidelines and predominantly for ANCA vasculitis, but you're now extrapolating that from there because these are all crescentic G and you don't have enough numbers. So again, it's 15 mg per kg and you lower it by 2.5 for each of those things, depending on which one they have, age or renal failure. And so 2.5. So which is why 15 got reduced to 12.5 and then got reduced to 10 and you're rounding out to 750. So that seems a reasonable dose for someone who has ANCA anti-GBM disease. What else can you give if you don't want to give cyclophosphamide?
Rituximab.
So how do you decide which one you want to give?
Age,
Age? है अंतर रिटक्स cyclophosphamide.
If there is life-threatening disease and there is risk to the organ, then cyclophosphamide is preferred. In rituximab, if we don't want to, if the patient is prone to, if the patient is very vulnerable to infections,
Is there data between rituximab and cyclophosphamide that which ones have more infections? We've had rituximab and ANCA and in anti-GBM, Ritux versus cyclophosphamide data. So which side has more infections?
Always cyclophosphamide.
Or means the randomized trials you'll see they're either equal or slightly towards cyclophosphamide in terms of infections. But mostly the randomized trials are about even for infections. So it's not that there is any infection data. So if you were to give him rituximab, what would be the problem? उससे क्या फर्क पड़ रहा है? उससे कोई फर्क नहीं पड़ रहा है. उन लोगों ने wherever you've given for rituximab for ANCA disease, the problem is going to be what? What else are you going to do with him? Plasmapheresis. When are you going to give your Ritux? When are you going to do your plasma? You do your Ritux and you do plasma the next day. All your Ritux is gone. With cyclophosphamide, that's not an issue. But with Ritux, that's an issue. So if this is an ANCA vasculitis that you are deciding not to do plasmapheresis for, then Ritux is fine. But if you're going to do Ritux and then you next day do plasma, now your Ritux is gone. So then all the 70,000, 1 lakh that you spent on the Ritux is all in the dustbin of your plasma machine, right? So that's what you have to be aware of, that it's easy enough for us to say we can use either or. But if your plan is to do plasmapheresis, then rituximab is going to be, you will need to make sure that you give enough gap between the Ritux and the plasmapheresis to let the Ritux get there. So if this was ANCA vasculitis, would you give plasma exchange or not? Yes. Okay. Based on what study are you wanting to give plasma exchange? अभी तक तो कहीं पे pulmonary hemorrhage है नहीं हमारे पास. What evidence do you have? X-ray में तो खाली higher markings हैं, कोई white fluffy shadows और alveolar hemorrhage तो है नहीं हमारे पास.
Pexivas advocates plasma exchange?
No, actually,
For or against?
Mapex
ठीक है. So Mapex में क्या criteria पे, what was the entry criteria for Mapex? Okay, so 5 and above. So patient meets that, creatinine is 9, you've started dialysis, so meets criteria for Mapex. So that showed benefit. Pexivas?
In Pexivas, there was no benefit.
No benefit. So
Even in patients who had pulmonary hemorrhage.
Yes.
Even in patients.
They had a subgroup of
They had a
pulmonary
subgroup,
hemorrhage.
so there was no
A
benefit.
fair number. I can't
So
remember the number.
how would you justify KDGO guidelines? See, again, there may be some who say that that's okay, but the point is there are these two studies. So if you're going to talk about plasmapheresis, you need to be able to justify it based on those two studies, right? So inside Pexivas, if you look at the whole group together, there is no benefit. But if you look at the criteria that is in MePEX, which are creatinine more than 5 or pulmonary hemorrhage, you look at the actual odds ratio. The odd ratio is 0.7. It crosses 1, but the relative risk is 0.7. So if you want to justify it, you will need to justify it on Pexivas by saying that they took low-risk patients, clubbed them with the high-risk patients, and overall it came out as negative trial. But within that, the high-risk patients were benefited, but because the number of events weren't high and their overall group was negative, right? So that is how. So if I'll give you a different example of how to think about it. You are jumping off from a plane without a parachute. Likelihood of death 100%. But I take only 10 of them and take 900 of them that are jumping from 1 feet. And I club both together. Jumping from 1 feet, everyone survives, with or without a parachute. Jumping from plane, all 10 die. 5 on this side, 5 on that side. With or without with parachute survive, without parachute die. Now those 5 are combined with 5 and 5 with the 95 here. Now study is diluted and it comes out even. But only if you look at that group, it is 5 and 0, survival and death. It's not 5 and 0 with plasmapheresis, but it's just a way of kind of understanding why, if you were to say that I am still a go-getter for plasmapheresis for ANCA vasculitis, despite Pexivas, you're going to need to go into the details and justify it based on that. And then the examiner will say, yes, this person has now read the study, knows the data, and can defend his argument. And in addition, in real life, use it for your patient while still in your heart saying, yes, I have reviewed the data and I am justifying it based on my read of the data, not on someone else's read of the data, whether it is KDIGO or someone else, right? Because then you can say, yes, this is what I have looked at the data, I have looked at the studies.
So do you change that? Do you do it?
I would. If they were ANCA vasculitis with severe disease, especially if there's pulmonary hemorrhage, I would still, with pulmonary hemorrhage. The other point is that their outcome was 90 days. What is the target of your pulmonary hemorrhage plasmapheresis? The purpose of plasmapheresis is to save them for 2 weeks while your cyclophosphamide and your Ritux kicks in. If you're looking at it at 90 days, you're again diluting the outcome that you think plasmapheresis will work for. The plasmapheresis is not to save them to 90 days or 2 years or 3 years or 5 years. The outcome that you want to look at is at 2 weeks and 1 month. That is what the plasmapheresis will save them from, not at 3 months and 9 months and 1 year, right? If you do a study of 60-year-olds, 20 years out, everyone is dead. The point is not that you can do whatever you want, they'll still die. The point is, what was the outcome that you were looking for? And so in Pexivas, again, the outcome they looked at was 90 days. That may wash out the impact of the plasmapheresis anyways. So if they had looked at a smaller time frame, earlier time frame for specific endpoints that we would say the plasmapheresis should work for, that would also be better. Again, that data is not available yet. So those are 2 reasons why I'm still not for everyone, not for the low risk, because for the low risk, Pexivas did a very good job of saying plasmapheresis is not good. But if you were still looking at the MePEX criteria of entry, creatinine 5.5 or more, or dialysis requiring, and pulmonary hemorrhage, there is an evidence of benefit inside the subgroups for that. So I think there's still some sliver of hope for us to continue to use plasmapheresis, but if you're going to do it, you will need to defend yourself. So be prepared to have those data ready right? Because otherwise, the examiner as well as in real life, people will question why are you doing it. Okay. So plasmapheresis, cyclophosphamide, steroids. How are you going to do your cyclophosphamide and what are you going to monitor?
So for cyclophosphamide, the first three doses can be given 2 weeks apart, and then the next doses can be given every three weekly. They should be given up to a maximum of 10 doses. And with the cyclophosphamide, we need to monitor the blood counts. Especially, it has a risk of developing leukopenia and thrombocytopenia. So we have to monitor. If the patient develops leukopenia, then we have to stop the therapy. We have to skip the next dose, and we have to wait for the counts to recover.
Okay. What else are you going to give this patient? Mesna. Okay. So that's one. So do you usually give Mesna?
No.
Anyone here has actually given Mesna to their cyclophosphamide patients? You don't.
कुछ नहीं होता. With
again,
our doses,
dose,
nothing
yes.
happens.
So the difference is
Chemo wala doses are
yes, the
higher.
chemo doses are higher. Plus, they give multiple doses on multiple days. They don't just give it on one day 0. They'll do 0, 1, 2. Those kind of doses that they give, and their doses are much higher. They're doing ablation. We're not doing ablation. We're just giving 10 mg per kg. So usually we haven't seen hematuria. So most people don't give Mesna for us. But what else would you? So you now discharged him. What was his discharge prescription that he went home with?
He with
Discharge में दवाइयाँ. What was his list of medicines on discharge?
a prescription of dialysis, maintenance hemodialysis.
Okay.
Since he was anuric, antihypertensives were given. We'll give him Visolon. He was discharged on 60 milligrams per kg, 60 milligrams per day.
बस खाली Visolon पे and IV cyclophosphamide every 2 weeks.
We'll give him PPIs and some antibiotics.
आउटडोर से प्लाज्मा एक्सचेंज हो रहा है उसका.
मैम
प्लाज्मा एक्सचेंज हो रहा है, नहीं हो रहा.
हाँ, few sessions हुए थे आउटडोर बेसिस पे.
So how many had he had before he got discharged?
4 before discharge.
4 before discharge, 3. And so he was coming every day. 1 day dialysis, 1 day plasma exchange.
Actually, initial 3 sessions were given consecutively, and then he was shifted to alternate day plasma exchange.
So dialysis भी चल रहा है ना? Anuric है.
Anuric and
Dialysis भी चल ही रहा
dialysis,
होगा.
plasma exchange and dialysis on the same day.
So एक ही फिल्टर पे एक ही
filter
डायलिसिस
से
पे
होता है
आप
वो.
एक ही डायलिसिस के टाइम पे ही आप प्लाज्मा फ्रीसिस भी कर रहे हो कि प्लाज्मा फ्रीसिस पहले कर रहे हो उसी दिन डायलिसिस कर रहे हो कि डायलिसिस पहले कर रहे हो प्लाज्मा फ्रीसिस कर रहे हो.
पहले डायलिसिस हो रहा था, आफ्टर दैट प्लाज्मा एक्सचेंज.
सो डायलिसिस हो रहा था डायलिसिस फिल्टर पे, उसके 2 घंटे के बाद या घंटे के बाद डायलिसिस का फिल्टर हटाया, P2 लगा के P2 से डायलिसिस. यू डूइंग ऑन मशीन, राइट? ऑन डायलिसिस मशीन, नॉट विद सेंट्रीफ्यूज. Okay. So on the P2 filter on the same day after dialysis you're doing plasmapheresis. That's quite risky and bold. I wouldn't want to do it on the same day.
Occasionally, I've done it for transplants. Usually, plasma exchange during the day.
And
Next
then
day is the
transplant.
transplant. Sometime
dialysis.
during the night they
You do
need dialysis. So,
Too much volume shift for my comfort to do both on
Yeah.
the same day, and that too for
So-
2 or 3 sessions of that. One
Yeah,
time
you
you
are
got
right in
stuck.
that.
One time you get stuck means there's going to be calcium fluxes, volume fluxes, a lot of flux.
so calcium
that is-
comes later now with the
so,
plasma exchange.
Plasma exchange. So
I
so
think it's
I
cost
would
cutting basically.
so I would be very hesitant to do 2 procedures on the same day. Once in a while you're stuck,
Yes.
or you did plasma exchange and some potassium issue happened or something happened and you needed to do dialysis that day also. That's a separate story. But as a planned event,
Yeah, it's a
I
bit
would
too
not be
much
I
for-
would not be comfortable doing both together. That would be a little too much for me. Okay, so we said Visolone, PPI. What else?
We'll give him prophylaxis for superated infections. Prophylaxis.
नाम बताओ यार, ऐसे
We'll-
ऐसे हवाई में
Valence
prophylaxis.
Septran DS for
ठीक है, Septran DS.
for pneumocystis jirovecii,
हाँ.
and for varicella we'll give him Valgan cyclovir, oral Valgan cyclovir.
So you gave him Valgan cyclovir also? दिया कि नहीं दिया?
I don't remember giving Valgan cyclovir. Septran DS was given.
Septran DS दिया था. So
Septran DS is fine. But I
Septran
don't
DS
think
is-
with cyclophosphamide people use Valgan.
again,
I-
you start doing it, you're going to be in more leukopenia with this.
Yeah, that
because
will
now you have
worsen the
cyclophosphamide, you have Septran, you have Valgan cyclovir. Your bone marrow suppression is going to be very high. So Valgan cyclovir I would also not do. And if you're worried about someone has had zoster recently or has zoster on Visalone, you would give acyclovir or valacyclovir, which will cause less bone marrow suppression. Valgan cyclovir is notorious for bone marrow suppression. So if someone's had zoster and you still need to give, or had zoster before, valacyclovir would be something that you would definitely want to give prophylaxis, but Valgan would be hard to do. If someone's had CMV, then it's a different story. You have a transplant patient, post-transplant, they have this and they've had CMV in their life. That's a different story, but okay. What else? Visalone, PPI, Septran DS. Or shell cal.
Shell.
So again,
Calcium and vitamin D.
so this should be spinal level, because this is something that you do day in day out. Visalone, cyclophosphamide, you're going to give for lots of different diseases. So Visalone 60 mg, you're now planning them for many weeks to months. Make sure you have them on a PPI. Make sure Septran, if it's depending on what additional medicines you're giving, and absolutely calcium. ये तो, and oral candidiasis is definitely going to be something that will come back to bite you if you haven't done it before. So वो करना है. And follow up, how are you going to monitor him?
Clinical response.
कैसे?
If
What would be the first response if he has to recover?
he'll start making urine.
Are you okay? Good. That would be the first response, obviously.
And then how would you plan his dialysis? And he will say, what are my chances? What are the chances that my kidney comes back and I come off dialysis? This is going to be patient and family. This is going to be, because you did the biopsy saying, maybe we find something, we'll treat and your kidney will come back. That's the purpose of the discussion. You've done the biopsy. You have anti-GBM disease plus ANCA disease with 100% crescents. So what's the likelihood of 100% crescents with anti-GBM coming off dialysis?
Actually, the prognosis of anti-GBM disease alone is worse as compared to the ANCA plus anti-GBM disease.
क्या? Sorry. ANCA disease, anti-GBM disease, ANCA plus anti-GBM. How do you grade and say what is the outcome?
The possibility of renal recovery and coming off dialysis is more in ANCA disease alone.
Okay.
Then on the second number पे ANCA and anti-GBM के chances are better as compared to anti-GBM alone.
I thought the two of them were similar. That was my read for this.
Somewhere here and there you'll find a trend.
But
P
I
ANCA
thought-
double wala is slightly better. But I don't think with 100% crescents anything will come back. Usually. That's the concept. And it's partly reflected in your plasma exchange regime. 3 daily, and it's already made every other day. Right? So that's like,
So someone with 100% crescents, chances
because
of
the hope of the
of-
unit is that it's not going to recover. So
would be
otherwise you would do 2 weeks non-stop. That's the
70 to-
usual recommendation.
70 to 80% are not coming back at all. They're not coming off
Unlikely to
dialysis.
recover.
So chances of recovery will be low. Somewhere in 20% would be what I would, 20-25%. So why wouldn't you give up and not do immunosuppression? So someone would say, if the chances are 20%, I don't have the amount of money to do 7 plasma exchanges. One exchange is 80 to 1 lakh. This is, now we're talking 7 lakhs. I don't have the money, or I don't think, if you say it's 60-70 in the favor of recovery, then I'll spend. 20% recovery chances, I don't want to spend. So what would you say? You want to do it, you don't want to do it? Transplant.
Give them
ट्रांसप्लांट
long
कैसे करोगे? ट्रांसप्लांट कैसे
अभी कैसे?
करोगे? बिना दवाई के, बिना प्लाज्मा के, बिना कंट्रोल के एंटी जीबीएम में 450 का टाइटर के साथ किडनी नया डाल दोगे? है ना, नहीं डाल पाओगे. So that is one reason to treat, is to say, even if you want a transplant down the road, even if this kidney doesn't get better, we have to control the disease so you could get to a transplant. So that is one reason for why you want to treat. What's the second reason?
If the patient has
Exactly.
patient could get pulmonary
He
hemorrhage
can get
after 1
pulmonary
week.
involvement afterwards. He may not have it right now, or he may have mild levels right now, but both those diseases can have other manifestations which are then life-threatening. Kidney disease is not life-threatening, we have dialysis, but the pulmonary involvement is life-threatening. So a second reason to treat is that pulmonary involvement, and pulmonary involvement would be there. So that's the second reason. And third is, for that 20% chance that this kidney can recover, especially in ANCA, we know there's a lot of people who will have case studies or case stories of people who were on dialysis for X number of days or weeks and were able to come off dialysis with a creatinine of 3.5 for some period of time after they got treatment. So again, so that would be another reason why you would say that we should at least do that. So you guys have questions on, you guys have ANCA and anti-GBM diseases, I'm sure you've seen those.
How long would you treat this?
Yes.
When do you stop?
Yes. When would you
When
say?
do you stop plasma
when-
exchange? When do you stop others? Let's say steroids and cyclophosphamide.
Ideally, plasma exchanges should be stopped when the antibodies are undetectable, anti-GBM antibodies are undetectable, but usually we do it for about 2 weeks. Cyclophosphamide is given for 3 months and steroids for 6 months.
Okay. Okay. So in this situation where you also have ANCA positivity, would you want to change it?
We should give maintenance treatment also in case of ANCA.
So because this is now, again, which is why you have to be very clear, what are you labeling this patient as? Is this just anti-GBM? Is this ANCA plus anti-GBM? If you're labeling him as ANCA plus anti-GBM, you would then need maintenance also. This is only anti-GBM, yes, it's a one-time event, you stop and you're done. But for ANCA, you will need maintenance.
I think the best way to think about this double disease in my mind is initially treat it like anti-GBM, later on treat it like vasculitis. And that kind of stays in your head. That's an easy way to kind of think about it. Because vasculitis is going to come back. It lasts longer. Usual treatment is about a year or at times much longer. And it does relapse. So think it like that one. Anything else? Or I think it's time we could finish it right here. Anything
Points
Richa
or
on your
comments
mind
which
on
we didn't
anyone
talk
else?
about? Anything that you wanted to discuss or talk about and didn't get covered?
So just this patient had the treatment initially, then he on follow-up he developed a pneumonia. So then his the next dose of cyclophosphamide was not given to this patient, and then he was treated with antibiotics. He got better, but he still remained anuric. So then his family was not willing to give him further treatment. So he was continued on steroids, oral steroids, and maintenance hemodialysis. But what else could have been done in this case?
Means again, in terms of disease treatment, you have steroid, cyclophosphamide, and plasma exchange. The only other possibility would have been Ritux, but with plasma exchange, that's going to be hard to do, and plasma exchange for anti-GBM is going to be something that you would want to do. So I don't think from that standpoint, but a 66-year-old who's going to get this is at very high risk for pneumonia or other infections as well. And the main thing that you would want to be sure about is whether this pneumonia is your run-of-the-mill pneumonia. You now have immunosuppressed, patients, or is this opportunistic infections? And third, is this one of the diseases with pulmonary renal syndrome? So you would want to be very, very clear whether which of those things, not just X-ray में pneumonia है, बुखार है, खांसी है, because that could be any of those three things. So whenever you have someone like this, you are likely to need a bronchoscopy to be sure what are you dealing with, because if you wait long enough, then this patient is going to be gone. So be very aggressive in getting tissue or microbiological data. He could have TB also. So get, and TB may not present with your classic lesions also. So it will be very important to be more aggressive in this kind of a situation of going in and getting bronchoscopic and microbiological samples. So that's going to be key in making sure that you know what you're dealing with, what antibiotics you want to give, because otherwise you can go all over the place. So that's kind of what I would.
Yeah, in a way, development of this pneumonia settles it for you in a disease which is unlikely to respond. You've given initial immunosuppression, the guy gets an infection. That in itself tells you, hold on, let's go slow on it.
Yes.
That's what it tells you, basically. So I would go slow on it. And a lot of patients, once they develop renal failure, the disease it's like a tornado. I call anti-GBM a tornado actually. It just comes for a few seconds, goes away. So it comes, hits you, and is gone. So it's possible even if we do not do much, and the patient has ESRD now, everything will quieten down. So the development of pneumonia has given you a clue in a way, if you think about it. So that's what needs to be done. Hold back.
Sir, after 14 days of plasma exchange, we do a titer, and if it's still high, do we continue with plasma exchange?
Depends on
the response,
the other things that are there. If you are noticing that he is now making more urine, it seems to be. So if he's anuric, 2 हफ्ते का दे दिया, you've given him a trial. Again, the question is going to be, what endpoint are you trying to achieve?
Again, you have to look at the probability वो ठीक हो रहा है या नहीं हो रहा.
So
नहीं हो रहा तो बंद कर दो. अगर ठीक हो रहा है, then there's optimism. Give him more.
Yeah, means if you've given 2 weeks, the titer hasn't come down enough. You've given cyclophosphamide also. He's on steroids. He's had pulse, and he's still anuric. At some point, and you know going into it that this is 100% crescentic. So at some point, there's a point of no return, where at some point you will also need to call it quits, in addition to the risk that the patient is getting. Because alternate day dialysis, alternate day plasma exchange, मेरे हाथ में तो वो हर दिन हमारे पास ही है. Because he's going to get 1 day plasma, 1 day dialysis, 1 day plasma, 1 day dialysis. So every day he's coming to us. 1 day for 2 hours, 1 day for 4 hours. So
Can we combine rituximab and cyclophosphamide?
Combined.
मर जाएगा, बस मर जाएगा. एक तो नहीं झेल पा रहा.
कहाँ? क्यों?
देखो, we are living in India. There are 2 problems. One, we are not as nourished as the Firangs are. Okay, we are poor. 2, our environment is very dirty. So we have a much mucor. COVID में यहाँ हुई है, दुनिया में कहीं नहीं हुई. That's because the environment is dirty. So ये जो aggressive immunosuppression book वाला है ना, it's very difficult to translate them into Indian scenario.
Our weights are also lower.
On the lower side.
We have more fat, less muscle. So there's a lot of other things when we dose things. All of the data is coming from West. Our side effect profile, our infection risk profile is much higher. So we have to be careful. Trying to treat the disease, sometimes we lose the patient.
Transplant, it happens every day.
Yeah. So
it's very
we have to
common.
be
Over
we have to be careful with what patient can still live on dialysis, and we've killed with immunosuppression. So sometimes we have to be careful where we go.
True. Thank you.
Thank you.
Thank you.
Well
Nice case, yeah.
Yeah, nice
But-
case and well done, I guess.
But again, I would You know this is ANCA and anti-GBM and this is RPGN.
yeah, there's a bias somewhere.
Don't block your differential. Don't
Bias
block
hai.
your differential. Don't block your differential. Exam mein, even if you know it or you don't know it, keep your differential broad. You're going to get in trouble. You're going to walk into traps. So keep your differential broad. And my suggestion is, on your daily rounds, on your daily patients, write a note, write a differential. Whenever you see a new patient, if you do it every
That
day,
would be a very good
if you do
exercise
it, if you do it every day, by the time you don't have to do it here. If you do it every day for every new patient that you see, by the time you go for an exam, you would have done 200, 300 of these. And you don't have to, you want to do it with your consultant, absolutely do it there. And have your consultant add to that list. What is your differential? How do you rate it? How do you grade it? Based on history, examine the labs that you have. Do your list and make it and run it with them and add or subtract. And then see what actually comes out as the diagnosis. So that will also help give you feedback to yourself, even if the consultant's not doing it, just do it for yourself. And it will give you feedback, and by the time you go to your exam, you now have 200 cases that you've done this for. फिर 200 बार कर लिया तो फिर 201 बार करने में हिचकिचाओगे
Very
नहीं.
diligent, yeah.
हाँ?
That
नहीं,
requires a
मैं-
lot of diligence.
नहीं, मैं
Or
कह रहा हूँ,
just mentally think
it just
about
takes
it.
5 minutes.
It
Making a
mentally
differential,
thinks about-
making a
think about
differential. Again, the reason I'm saying is thinking about it, keeping it in your mind, it's not going to be very good. Do it on paper, write it down, and then look at it, because then it's forcing you to put on paper. It doesn't have to be a paper that anyone else sees. It can be something that you have in your pocket. But write it down and then come back to it. Because as you do this over and over again, you will get better and better at it. And you will get your own feedback. It doesn't need someone else to give you feedback. You have the patient, you have the reality of life. And that will give you, and that will hold you in good stead, not just for the exam, but also for real life, where you are doing this over and over again. Once you go in practice, no one's looking over your shoulder. Whatever differential you've made and what workup you do, no one else is going to come back and say, hey, think about this, do it. छूट गया तो छूट गया ना, patient गया तो गया फिर. So again, this is the time where you have opportunity to do this. So I would strongly encourage, and writing it down just clears it in your head. I have put my money on this. वो जो है ना, that is very important.